Today I'll be talking about approach to chest pain with ECG. Now, any patient, whether diabetic, hypertensive, above 40 years of age, if he is presenting with a chest pain which can be central, which may be associated with diaphoresis, severe sweating, the pain which is radiating towards the jaw or toward the left upper limb or toward the right upper limb, but usually chest pain of cardiac origin does not go below epigastric region. So it can also present with uneasiness or central heaviness or tightness in the chest or uneasiness. So if the patient is presenting with the chest pain, the first thing to do is an ECG. So whenever we do ECG, I have a very simple and effective approach. If the patient has pain, chest pain, and ECG shows ST elevation in more than two consecutive leads, if there is ST elevation in more than two consecutive leads, we can simply label it as ST elevation MI. We don't need TROP-T, CKMB also. The patient must fulfill at least 2 out of 3 criteria. The first criteria is typical symptom, which is chest pain or sweating or palpitation or shortness of breath. These are all chest pain equivalents, and the remaining 2 criteria is either the patient must have ST elevation or either the patient should have cardiac biomarkers positive, which can be TROP-I or troponin T or CKMB. So CKMB is very non-specific, whereas troponin I and troponin T, they are very highly specific. Troponin I, as it comes in alphabet also, it comes earlier than T. So troponin I usually comes early in the blood and troponin T comes late in the blood. It may take around 6 hours for this troponin I or troponin T to come into the blood to a detectable level. That is the reason why any patient presenting with chest pain, if they have negative troponin I or negative troponin T, we repeat the troponin I or troponin T after 6 to 8 hours of sending the first blood sample. If the first blood sample shows positive or raise troponin I or troponin T, it means the patient has ACS, that is acute coronary syndrome. Acute coronary syndrome comprises of 3 things. First is ST elevation MI, second is non-ST elevation MI, and third thing is unstable angina. So it's very simple. Patient presenting with chest pain, patient has ST elevation, the patient has ST elevation MI. If the patient is presenting with ST elevation, if the patient is presenting with the chest pain, but the patient does not have ST elevation, the patient has ST depression, then we need to have the troponin I and troponin T. If the troponin T I, if one of them is positive, then pain is there, troponin I, troponin T is positive, but ST elevation is not there, we can label the patient as having non-ST elevation MI, because it has the positive cardiac biomarkers and the patient is presenting with chest pain. If the patient does not have this cardiac biomarkers positive, and if the patient has presented with chest pain and the patient has this ECG changes, but the markers you have repeated after 6 to 8 hours and they still come negative, then it means it is not MI, then it is basically unstable angina. So it's very simple. Pain and ST elevation in more than 2 consecutive leads. Now consecutive leads means the ST elevation has to be in at least 2 consecutive leads, and the consecutive leads comprise of lead 2, 3 AVF, which we call it as inferior wall leads, and the culprit artery will be right coronary artery in most of the cases. Then lead 1 AVL, Then V3 to V6 we call it as lateral wall, and mostly very commonly the LCX will be culprit into this. Lead V1 to V4 may show the similar changes, and the most of the time the artery which is culprit is LAD. So uh, these are the consecutive leads which very commonly we follow, and the ECG changes must be present in at least two consecutive leads, like it should be there in lead 2 and 3 and AVF. Only ST elevation in lead 2 or only in lead 4 is not good. We don't consider it as significant. So ECG changes must be present in two consecutive leads. Now in here we can very nicely see that the ST depression is there. So this is the baseline. This is the baseline. Whenever we are saying ST elevation, we have to find this baseline. This is the baseline. So this is the running baseline. This is the running baseline. We can very nicely see that this is the baseline. This is the running baseline. If you want to see, this is the running baseline, this is the running baseline, we can see a very nice ST depression of around 3 millimeters, 3 to 4 millimeters in lead V3, in lead V4, in lead V5 and in lead V6. So there is extensive anterior wall involvement, there is extensive anterior wall involvement. In lead AVL also there is slight T wave inversion, and in lead V1 lead A1 there is very mild T wave inversion, but there is marked ST depression and T inversion in V3 to V6, which suggests that the patient may have left anterior descending artery involvement. So if there is no ST elevation, so this is not definitely ST elevation MI. So if the patient has this STT changes with positive troponin I or positive troponin T, then this is non-ST elevation MI. If the patient's trop T, SICMB, troponin T comes negative even after repeating the test after around 8 hours, then we will label this patient as unstable angina. So it's very easy and very crystal clear to understand the differences between unstable angina and stable angina. It is very easy. Unstable angina is a part of ACS where patient present to the hospital to the casualty. In unstable angina, the chest pain usually lasts for more than 30 minutes, whereas in stable angina, the chest pain usually always lasts for around less than 10 minutes. The stable angina pain gets better after taking nitrates or after taking rest, whereas in unstable angina the chest pain does not get better even after taking the nitrate, sorbitrate, or even after taking rest. So most of the time if the patient take rest for 5 minutes, 10 minutes, the stable angina pain completely goes off. And the stable angina pain usually always comes while walking or while doing some exertion or while doing any activity, whereas unstable angina, even the patient may get the pain even at rest. That is the reason why the patient present to the hospital. So these are the findings, these are the things which are very interesting, and we'll come up with again some other topics as well. And thank you.